Jim, please describe the service you offer in Northern Ireland.
What we offer is a complete outsourced managed service, which starts with a patient being referred on to the service. The patient would typically have a long-term condition, such as CHF or COPD or diabetes or stroke. A patient gets referred on to the service, and then we as a provider are responsible for the complete delivery of that service. That includes contacting the patient, getting consent for them to be on the service, installing equipment in their homes and training them on how to use it, gathering the data then from those homes. It's sent back to a data centre, and in that data centre we have a team of nurses who are looking at the data that comes back. The data is automatically flagged where a vital sign that a patient would take is outside of parameters that have been set by their doctor. In that case, one of our nurses will contact the patient and will try to understand the reason for that. It may be something simple. It may be simply that they didn't take their medication that morning. It may be that they have another infection, for example, that's causing maybe their blood pressure to be higher or their temperature to be higher. Our nurses will make the decision as to whether it's necessary to escalate their condition to their primary care, which could be a community nurse, it could be a GP, it could be a consultant, and we'll provide access. So if we make the decision to escalate that patient's condition to one of their carers, then we'll also provide access for those carers to access the system and see the information. What those clinicians will be able to do then is access the system and see over a period of weeks and months what the vital signs for those patients have been, how they've answered certain health questions, and they'll get a real vast amount of information about the patient, and they'll be able to take the appropriate action then. So the service we're providing is from referring somebody onto the service through to discharging them from the service. Patients will typically be enrolled on the service for a period of weeks. It might be, depending on the condition, it might be, if it's stroke, it might be a relatively short monitoring period post discharge from hospital. It might be a period of a couple of weeks. If it's a condition like COPD, it might be 13, 26 or 52 weeks of service. So it's a complete end-to-end service when somebody is referred onto the system, and an online system to enable that referral to happen and to enable clinicians to access the information when they need to, as well as providing the ongoing monitoring for those patients.
Can you extrapolate on the ICT aspects of this?
Yeah, obviously it's a very broad service, and because it's an end-to-end service, there are a lot of different ICT aspects. So we're providing the basic IT infrastructure, which includes linking our service to the Health and Social Care Trust's IT infrastructure. So that includes us installing, for example, MPLS links between our service and the Health and Social Care Trust's IT infrastructure. We also provide obviously the links from the patient's homes and head back to our data centres, so the information can be transmitted over a simple telephone line, or it can be transmitted via GPRS. We then provide a suite of applications in the monitoring centre to allow things like online referrals to happen, to allow clinicians to access the information. We also provide a patient portal which allows patients to go to a website and see their own data, of course in a secure manner. So there's a suite of applications that support that support our nurses in the monitoring centres, that support clinicians to access the system, and support healthcare professionals to refer and discharge people from the service.
So Malachy, what about the cost reduction and quality improvement aspects?
The major goal of a service like this is to try and reduce the utilisation of hospitalisation of acute hospital sectors. If it costs perhaps €1,000 a day to have somebody in a hospital bed, it might cost €2,000 a year to have somebody treated for a similar condition in their own home. So the economics of treating people away from the hospital is the main goal of this. In terms of the targets we have set for the service, getting maybe 25% reduction in bed days of care from a population set like this would seem to be achievable. Getting 19% reductions in emergency visits from the patients within this service would be a goal for us, and improving the patient's quality of life. So surveys around the world have suggested perhaps 86% improvement on health-related quality of life are the targets we're trying to set for this. The idea of the economics coming from nursing community, so that we're trying to make the nursing visiting service more efficient by having a technology element to it, so to improve the number of patients that any one nurse can monitor. So a single visiting nurse perhaps could monitor tens of patients in her caseload, but with a monitoring element to it, she might be able to monitor, one nurse could monitor 200 patients or 400 patients at various ratios around the world. So there's efficiencies in reduction of hospitalizations, and there's efficiencies from using the nursing centres better.
Would you be looking at the German-speaking region for such a service offering?
We would see Germany as a key market for this. The demographics of elderly people within Germany are quite strong. The demographic trend towards an elderly care community would suggest that Germany will have to adopt a model like this. You can't simply hire more and more nurses and hope that a service that you can deliver usual care in that manner. There has to be an element of, if the old people are coming and they're bringing more and more chronic diseases with them, we have to treat them in a different manner. That's true for Germany as it is for most other ageing populations around Europe. When we look at America, they've got quite a large mature programs like this. The Veteran Health Association has currently 45,000 patients on it, growing to 75,000 patients, and suggesting that they may spend $1.38 billion on this service over the next 6 years. So the economics of doing it are inexcusable, and the rationale for doing it with ageing populations is definitely there. And Germany has got an ageing population has similar demographics to the rest of Europe. So yes, absolutely.